join, that would be great. Okay, well, we're going to get started. Welcome to our July Gero Competency Training. It's part of a series that we put on almost every month throughout the year. We take a few months off. And so today we are having Nirmala Dhar doing Understanding Anxiety in Older Adults. And before we get into the training, we're just going to kind of do some housekeeping. Please keep your mics muted. We're going to have a time at the very end to do question and answer. So utilize the chat to kind of put it down so that you don't forget about it. And then we will answer those questions at the end. You will be receiving a follow-up email from us, the OABHI, and of Josephine County. And that email will have the slides, they will have a link to the recording, and any training materials that Nirmala would like us to send out. And then also there's going to be a survey if you want CEUs, and then also we will be doing an additional survey for certificate of attendance. To claim the CEUs, you do have to attend the entirety of the training. And once again, the recording will be posted on our YouTube channel. And there is a link to that that we'll send out as well. Okay, so the Older Adult Behavioral Health Initiative of Oregon is something that was launched in 2015. The Oregon Health Authority funds and supports somewhere between 20 and 24 older adult specialists across the state. We do lots of good work in collaborations and coordinating. We do workforce trainings like this. We do community health and wellness classes, and we provide complex care consultations. So if you work with older adults, any county in Oregon, you can go to our website and find out who your specialist is. And please reach out to them to get an intro meeting because we are a really great resource. Okay, so our next Gero Comp training before we get into Nirmala's bio, we are doing Beyond Bereavement, Understanding Grief, Loss, and Resilience in Later Life. Dr. Serena Saturn is a neuroscientist, and she does a wonderful job of integrating neuroscience with contemplative practices, culturally grounded approaches, and community-rooted wisdom in advancing equity. So please consider registering for this as well. And again, we provide CEUs for free for these trainings. Okay, so I'm going to stop sharing. Let's see. There we go. And I want to introduce Nirmala. So Nirmala Dhar is a licensed clinical social worker with a master's degree in social work from both the Brown School of Social Work at Washington University in St. Louis in Missouri and the Bombay University in India. She has 36 years of experience in all aspects of behavioral health programs in the public sector in Missouri, New Jersey, Oregon, and she currently serves as the lead, the senior policy analyst and the older adult behavioral health lead strategist for the Oregon Health Authority's Division of Behavioral Health. She recently played a really big part in funding and establishing the Center of Excellence for Behavioral Health and Aging, OSEBA, at Portland State University, and that was a working together with OHSU, and she continues to be an active partner in that project. So we are really excited to have Nirmala do these trainings and to be our our supervisor for our older adult behavioral health initiative. So welcome, Nirmala, and the stage is yours.
Thank you. Angela, how are my slides appearing?
I think that they're appearing in your presenter mode, so you might need
Okay,
a
so let
flip.
me switch my
Yeah.
now.
Yep, there you go.
Okay. Now, when I have this, I don't see folks well because it takes up my entire screen. So I will not see if anyone raises their hand or anything like that. So please interrupt me, Angela or Luisa, if you'll need to. So
Abs-
oh my gosh, I have the wrong one on. I'm sorry.
That's what you're doing later today, right?
Yes, I'm very sorry. I was so excited that everything was up and running and okay, give me a moment. My
You are
apologies
fine.
for that. Okay, now let me see. Um, give me a moment. Now I'm all frazzled and upset. So, uh, which is good practice for anxiety, correct?
Yeah, I
Uh,
was just gonna say, do some breath.
okay, I need to just go back here, and I think I've stopped sharing, correct?
Yep. Yeah.
Okay, let me escape from here and get to my uh, to the presentation that I'm supposed to give. Uh, let's see now. Where is share? Okay.
We have participants sending you some compassionate energy right now.
Okay, now can you see this?
Yes, and
That
that's a
looks
really great
way
graphic.
better. Way better. My apologies. Okay. So I'm very excited to be here. Anxiety and depression are areas of deep interest to me, and I have worked, with anxious and depressed clients for much of my career. So this is something I'm deeply committed to uh, in understanding anxiety in older adults. By the way, there was a report just published by SAMHSA on it's called the utilization of mental health services in community mental health programs, and the top two diagnosis for adults and older adults was depression followed by anxiety. It was not bipolar disorder. It was not borderline personality disorder. It was not, I don't know, OCD or schizophrenia. It was depression and anxiety. So I think you're in the right place this morning. So thank you for being here. Thank you, Angela and Luisa, for inviting me. And I love the work you both are doing in Josephine County. Now, how do I make this move? Okay. Okay. So my learning objectives, I'm not going to spend too much time, but you will understand unique aspects of geriatric anxiety. You will increase your knowledge about how do you assess and diagnose anxiety. You will understand what are some evidence-based treatments for older adults who are anxious. And you will become more familiar with cognitive behavioral therapy and other evidence-based interventions for older adults who are anxious. So let's start at the very beginning. What is anxiety? So have you ever had to speak in front of a large crowd, especially in person? I mean, it's nerve-wracking virtual too, but in person. And you're not used to it. You don't do it often. Did your heart beat faster? Did your palms get sweaty? Did you have a huge knot in your stomach? But guess what? That is the feeling of anxiety in your body. Now imagine living with that feeling from the moment you get up until you go to bed every day, regardless of where you are or what you're doing. That is the constant feeling you have in your body. And what if you cannot make those feelings go away? They're there with you 24 hours. Did you know that anxiety is a normal emotion and it's like good for us? Why? Because it helps us recognize threats or problems and helps us to solve them. So there's a healthy form of anxiety. Why? Because it helps you perform at the top of your game. For example, you have a job interview day after tomorrow. It's very healthy to be anxious or have anxiety. Why? Because that will probably be a catalyst for you to prepare for the interview, correct? You may anticipate, hey, what are some questions they might ask? You may even find answers for the question. Then you may sit in front of a mirror and say, okay, I'm going to rehearse, how I'm going to present myself, how I'm going to talk. So can you see? It helps you problem solve and prepare, because the threat is, hey, I need to do well at this interview, and because I want the job. And so their anxiety is healthy. It is not healthy when it lasts for days and months and goes beyond a specific stressful event, or when it starts interfering with the person's life. Like I said, imagine every day you get up with that, the pit in your stomach is fluttering, your heart is racing, your palms are sweaty, you're vigilant all the time. It's not sustainable, correct? So which one is it? Is it like everyday anxiety? Everyday anxiety, like I just said, worry is good if you're going for a job interview. Or is it an anxiety disorder? Or worrying about paying bills, landing a job, a romantic breakup, or other, that's everyday anxiety, which all of us, it's like universal. Or you can also be somewhat embarrassed and self-conscious, and sometimes you may feel awkward in social situations. Now, anxiety disorder, remember the word here to concentrate on is disorder. It is constant and unsubstantiated. That means there is no cause for worry that causes significant distress and interferes with your everyday life. You can't concentrate. You can't sleep. You stop driving your car because you're afraid. You don't leave your home. You avoid answering the phone. You fear being judged, embarrassed, humiliated. So that's the difference between like what's normal anxiety, because you can't just be so cool all the time, correct? It wouldn't be natural. But then know what is a disorder. Again, I'm not going to go through every one of them. For example, everyday anxiety, you can have realistic fears about a dangerous situation or a place, which is what protective, right? If you're afraid of walking along some particular street at 12 midnight, then go with that hunch. Go with that fear. I won't walk there. That is not anxiety disorder. But then there are irrational fears where you avoid places or place. I won't fly ever on a plane because I know my plane will crash. That's an anxiety disorder. Did you know we all have a fear center in our brain? I call it hardwiring, that we are all hardwired for fear. All of us, universal. And it's that little yellow, it's really here it's like big, on this brain, but it's really like a pea-sized organ, very small, called the amygdala. That is our fear and anxiety center for all of us. And what does it do? Its main role evolutionarily is for us to avoid danger. It helps us avoid danger. Because if you have no fear, can you imagine how you're putting yourself at harm? Because we have this, it motivates us to avoid danger. And that is the anxiety and fear center in our brain. So anxiety disorders are persistent conditions that impair your everyday functioning. They are also highly comorbid, or that means they co-occur with depression. And so anxiety disorder causes feelings of fear, worry, apprehension, which means, oh my gosh, I don't know what's going to happen. This constant feeling of dread that are excessive, disproportionate to the problem or the situation that is feared. So it's totally out of sync. You know, having a little bit of fear is good, but when it's disproportionate, it paralyzes you. So what is stress? So many people say, I'm stressed. You know, is that anxiety? Stress is a physiological response connected to some kind of external event. So for stress to begin, there has to be an external stressor. This could be some circumstance, it could be a deadline you have at work, or it could be some kind of scary medical test. You have to go for an MRI to see if there's something, you know, whether you have a tumor in your brain. So can you see there is an external stressor? So for you to experience stress, it has to be connected to some kind of external event. And so it is defined as a reaction to changes of forces that exceed your individual resources to manage it for that particular stressor. That's what stress is. So there's a difference between stress and anxiety. What? Stress is time limited. Once you have the MRI done, the results come back, hey, your brain is just fine. Your stress should mitigate and actually disappear. So it's time limited, and often it results in a solution and you move on. For example, the other example may be a job interview, or you're going on a date after very many years, or you're sitting for a licensing exam. Those are stressful events, means there's an external stressor. Anxiety is, on the other hand, a perception of threat without actual danger. There is no real external threat out there, but you have this constant perception of threat. It is future oriented. Something bad is going to happen to me, and there's no solution. It is the what if. What if it happens? What if I board the plane and it crashes? What if I drive this car and I have an accident on I-5? So it is the what if mindset. So there's no actual stressor or problem. And there's really no solution to what if, right? Because it's future oriented. If stress or anxiety do not go away, they start interfering with your life. And it can affect your health and your everyday living activities. Did you know it's one of the leading causes of cardiovascular disease, immunosuppression, digestive problems, reproductive health, sleep disturbance, and failure to perform well at work or in any of your other chosen and valued roles. So it robs you of the quality of life. So what's the prevalence? Among older adults, and I'm going with the age range of over 55, about 3.5% to 10% have depression. So 10% is high, it's a range. It's higher than younger people. And here are some of the risk factors for older adults. Female sex, lower education, being unmarried or unpartnered. By the way, being partnered and married is a protective factor for many things, many mental health and health, by the way, health diagnoses. And you have 3 or more chronic conditions. That means you have arthritis, you have COPD, you have depression. You're very likely to develop anxiety too. Here are protective factors. Remember, we use this framework of risk and protective factors. And what do we want to do? We want to actually cultivate protective factors. So here are the protective factors. High perceived social support. That means you have this psychological sense that you have a really good support system. Which means what? Social connection. Regular exercise and positive health habits, and higher levels of education. Remember, I talked about female sex as a risk factor. 40% of women. That means how many of us is there? 37 what people here? Calculate what 40% of that is. If we were a little city, that many people, that would be a little less than half of us on this call, if we were all women, would have anxiety. If we are older, 40% of women have feelings of uncontrollable, this is actually during the lifetime, not just older, uncontrollable worry during their lifetime. Look at that, double the rate of men and boys. And just for each age cohort, reasons for worry and anxiety could be different. And you'll see what older adults worry about most. But the fact is 40% of women, double the rate of men. Now, when you're doing your assessment, keep that statistic in mind. Why? Because it's highly prevalent. Now, remember, our talk is on older adults. What's common? 3 to 20% of older adults meet criteria for anxiety disorder in nursing homes. So any of you who have done PASAR level 2 evaluations or go into nursing homes to see clients, you're part of the ECOS program, expect 1 in 5 of your nursing home residents to have an anxiety disorder. And sadly, it is unrecognized by nursing home staff. Very common are what we call generalized anxiety disorder. I'll talk about it, and maybe some specific phobias, but I would say generalized anxiety disorder, sometimes called GAD, G-A-D. Detection and diagnosis is often complicated. That's why you're here for this training today. And anxiety increases your risk for falls if you're older. And guess what? 1 in 3 older Oregonians falls. Now, imagine if we can help people manage their anxiety. It may decrease their falls, correct? Because I'll talk about it later, there's a certain kind of anxiety that comes with falls. So it's very important that we recognize anxiety in older people. Why? Because they're likely to experience impairment from clinically significant anxiety symptoms. And sometimes they may not meet the full criteria for anxiety disorder. We've already said it's very common in people with chronic health problems, especially the more chronic health problem, the more likelihood of having anxiety. Both anxiety disorders and clinically significant symptoms of anxiety are associated with poor quality of life, greater disability, increased healthcare use. What do I mean by poor quality of life? You're not sleeping well. Now, can you imagine if you don't get restful sleep, how the rest of your day will go? You're probably irritable, you're fatigued, you can't concentrate, you may fall. Can you see how it cascades in terms of your quality of life, which then will lead to greater disability? And you'll show up more in the emergency room or at your doctor's office, or you're repeatedly calling the doctor's office. Even mild anxiety is associated with reduced cognitive performance. That means it impairs your memory, your concentration, your ability to learn new things, your ability to plan and organize. And the presence of the most common anxiety disorder, which is, generalized anxiety disorder, is associated with an increased risk of suicide among depressed older adults who come to primary care and to specialty care. That means if you have anxiety, it elevates your risk for suicide. So detection and understanding of anxiety in older adults is a critical first step in your assessment and connection to appropriate treatment. So for older adults, these are things you should know. They overlap with medical conditions. Express anxiety as medical or somatic symptoms. That means physical. I have pain, such as pain rather than psychological distress. They won't say, oh, I have an apprehension, constant apprehension or fearful. They will say, I'm in pain or I feel stressed. They're likely to report feeling fearful, afraid, or scared. Late life anxiety disorder co-occurs with depression. It affects older adults far more profoundly than younger people. Anxious geriatric patients are less independent, and they increase burden on family and even professional caregivers. And sadly, they have decreased life satisfaction, poor self-perception, and increased loneliness. And the shocking thing, remains underdiagnosed and undertreated and challenging to treat. I'm not going to go over all of this, but very quickly, this is a nice slide where it tells you what's the difference between young people and older people with anxiety. And you can see for older people, uh, 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 cognitive and somatic distress, they talk a lot about this. And more severe physical symptoms, more impairment, in like independence and independent living, and then social functioning. Here is a nice Venn diagram of depression and anxiety. The red is depression, the blue is anxiety, and the middle is what's common to both. And you can see there are differences, but look at the intersection. Excessive worry happens in both. There could be agitation, there could be restlessness. So this is a nice Venn diagram for you to keep on your desk if you're say an intake assessment therapist of some kind, where you're looking at both. So we've already talked about depression and anxiety, but did you know anxiety is very common in patients with dementia? And it's like shocking. I mean, it's huge. The prevalence is very spread out, but it's a lot of people who have dementia who are also anxious. This is also associated with poor quality of life. We talked about that with the other co-occurrence, behavior problems, impairment, sleep disturbance, all of that. And it is also a predictor for future nursing home placement, suggesting that it is a serious caregiver burden. And here, Again, I'm giving you some differences between anxiety and depression. Remember, they co-occur, but they're also different. So in terms of symptom persistence, for anxiety, it should not be persistent after the situation goes away. For generally, it is future oriented, worries about the future. In depression, they worry about the past. You know, that I'm a failure. I've done nothing good in my life. In anxiety, you're often hyper vigilant and alert. You know, that's what apprehension is. You're so afraid all the time that you're trying to protect yourself, so you don't sleep and you're scanning and, you know, trying to keep yourself safe. While in depression, you can be very apathetic and slowed down. In anxiety, you don't have these kind of slowed down thinking and all of that. You know, while in depression, you can. We call that psychomotor retardation, where you're really slowed down. You know, everything is like a huge chore. That doesn't happen in anxiety. And in anxiety, you often have difficulty falling asleep at night. Why? Because you're worrying, you know. But in depression, early morning awakening is often the issue. That means you can't sleep consistently throughout the night. Okay, I've just included this study if any of you are interested. The effects of anxiety on all-cause dementia. This is free for you to download and look at it. What it essentially says is chronic and new anxieties were associated with an increased risk of all-cause dementia. And this was significant in those who were 70 years and older and younger, sorry. So what does this study suggest? The timely management of anxiety may be a strategy to reduce dementia risk. Remember, we are doing a lot of work around risk reduction for dementia, and this is one possible strategies to identify anxiety earlier and help manage it so that it would reduce your risk of going on to actually getting a dementia. Did you know medications can trigger anxiety? Medications with caffeine, corticosteroids. You know, my daughter, when she was younger, had to be on prednisone off and on because of asthma. And I remember we had to write to the school at that time, you know, that tell her, no, this is not ADHD. This is a reaction to steroids. So imagine if you're 80 and you're on prednisone. Stimulants, asthma medications, thyroid medications, decongestants. Do you know it is a controlled substance, Sudafed, in Oregon? Because it's used for, you know, illegal uses in Oregon. All of these medications can trigger anxiety. Remember I said 3 or more chronic illnesses will put you at high risk for anxiety disorder if you're older. Look at all the increased prevalence of anxiety disorders with cardiovascular disease, gastrointestinal disease, respiratory disease, migraines, pain, and cancer. Odds of anxiety increase with increasing number of chronic medical conditions. And do you know by age 66, older Americans have 1, 2, 3 chronic illnesses. And then we've already said it is undiagnosed and undertreated. Why? Because older adults likely focus on physical symptoms of anxiety. Like I have an upset stomach. I can't sleep well. They are less likely to report cognitive symptoms like I worry a lot. I have this fear in my, I have this constant fear. That's not what they're going to tell you. This could be due to lower rates of mental health literacy with this current older adult cohort. So how much more education and awareness we need to be doing in our communities for older adults to tell them that what is anxiety and that there's help to increase their mental health literacy. Look at what it does. It increases hospital stays, cost of healthcare, a chronic illness and disability, unexplained symptoms causes memory impairment, increased loneliness, all of that by this under recognition and under treatment and lack of mental health literacy. Look at this is anxiety disorder co-occurring with some of these medical comorbidities, heart disease. Following a heart attack, it is well known to have high levels of anxiety, prevalence of anxiety. COPD, chronic obstructive pulmonary disease, especially in the advanced stages. Parkinson's disease, 40% of people with Parkinson's disease also suffer from an anxiety disorder, commonly GAD, generalized anxiety. Endocrine disorder, malignancies like different cancers, substance use. We've gone over risk factors, so I'm not going to go through them again. Here are common fears. Remember I said maybe what younger people worry about is different than what older people worry. This is what older people worry about or anxious. Declining health, onset of memory problems, losses, fear of falling, financial hardship, fear of dependency for ADL care, loneliness, lack of social support, fear of pain and death. Very different from what maybe a 30-year-old would be worrying about, correct? I'm very anxious about falling. What can I do? Do you know there's something called fear of falling? That's a form of anxiety. Many older adults, especially if you've fallen once, have an excessive fear of falling again, which is a very serious concern and anxiety disorder that can lead to what? Inactivity, shrinking of muscle mass, disability, and falling again. Why? Because it paradoxically increases your risk for falls. Did you know it's very common to have anxiety with COPD, especially because the disease in itself is like breathlessness, shortness of breath? Can anything be more scary when you're doing this and you can't breathe? Breathlessness indicates that your body needs more oxygen, right? And energy when it's exerting itself. However, breathlessness is common in people with lung and heart conditions, correct? As well as with people who are maybe overweight and not physically fit. Those with COPD will experience breathlessness as the disease affects the breathing tubes or airways to the lungs. And this feeling of breathlessness may increase as the disease progresses. Remember, feeling of breathlessness. As a result, these constant feelings of being out of breath, I can't breathe, I'm going to die, can create greater feelings of anxiety. So it co-occurs at a very high rate with COPD. How many of you work with older adults with COPD? Have you ever asked their primary care doctor or have you diagnosed them with anxiety? And really the interventions for COPD and anxiety, aside from many other anxiety techniques we're going to talk about, is this use of, and you teach it, use of pursed lift breathing. I am no guru at this. Please look it up. Helping them interpret their symptoms more realistically, helping them practice mindfulness, where you're then calming your nervous system, your stress activation, calling a friend, which is a diversion or a distraction. These are all the interventions for COPD and anxiety. Did you know that if you're doing a thorough assessment of an older adult, that you should rule out all of this, including what we call MVP, mitral valve prolapse, because it can mimic anxiety. Then evaluate for substance abuse, including caffeine, any withdrawal, caffeine and nicotine. So how do you diagnose the most common form of anxiety called generalized anxiety disorder? It is the presence of excessive anxiety and worry about a variety of topics and events, or worry occurs more often than not for at least 6 months, and it is excessive. The worry is experienced as challenging to control. The patient or the client is telling you, I can't control it. The worry and anxiety are accompanied with at least 3 of the following physical or cognitive symptoms: edginess or restlessness, tiring easily, that means you become fatigued. Can you imagine if your brain is on overdrive all the time, trying to figure out what is around the corner? You're afraid. You will feel fatigued. Impaired concentration. Or your mind goes blank, that feeling, irritability. Increased muscle tension and soreness, because you are so activated all the time that your muscles are tense, and it leads to soreness and pain. Difficulty sleeping due to trouble falling asleep because you're worrying. So you have to have worry for 6 months and it's excessive, and you have to have any 3 of these 6 symptoms to have a diagnosis of generalized anxiety disorder. Then we have social anxiety. It's an extreme fear of being judged by others. Like, it is disabling. It is unremitting. And it's generally like a lifelong disorder. You don't develop it at 80 years old. And it can lead to other problems like alcohol use, drug use. Guess why? They're trying to calm their nerves often, right? Or agoraphobia, they just don't leave their home. They are paralyzed by fears that they will be humiliated or embarrassed in front of others. So they drop out of school, they lose their employment, they have no friends because of this extreme paralysis that the fear induces of humiliation. Then there's panic disorder. Sometimes we all call it like panic attack. It happens due to unexpected or stressful situations. It is a spontaneous attack of intense fear and discomfort, which can last from minutes to an hour, never beyond that. Symptoms are generally increased heart rate, chest pain, chills, hot flushes, dizziness, crying, fear of losing control, fainting. Guess what happens when people are feeling all of the symptoms? It is one of the leading cause of visits to the emergency room, thinking you're having a heart attack. And you're actually having a panic attack. And there are many other anxiety disorders. Separation anxiety disorder is really in children. Selective mutism. Did you know that it's an anxiety disorder? In my 40-year career, I've worked with two people who had selective mutism. They stopped talking. Specific phobias, many of us have heard of, heights. My husband has a phobia of heights. So we never go, you know, in a sky train or, in a gondola above a mountain because he's afraid of heights. Some people are afraid of certain animals. I know people who faint when they see blood, even when you have to draw, for labs. Airplanes is very common, even elevators. Agoraphobia is when you don't leave your home at all. You totally avoid everything. We talked about medication and substance-induced anxiety and anxiety due to some other medical condition, like we talked about, mitral valve, and there are many others. So this is like the gold standard screening tool. And I've asked Angela and Louisa maybe to send you all a separate PDF of this screening tool called the Generalized Anxiety Disorder 7 questions. And these are the questions. I don't know how many of you use it. If you do, I'd love for you to put it in chat. And more beyond that, how does it help you create your treatment plan? And how do you use this to see whether your client or patient is improving? And if you can see here, it tells you how to interpret the score. If you have 0 to 4, means you don't really have an anxiety disorder. You may have worry occasionally. If you have 5 to 9, mild, 10 to 14, moderate, 15 to 21, severe. So it's basically, we have to calculate all of the responses. This is a slightly different one, which is used for older adults. I mean, GAD-7 is good. This is called the GAS-10. It is geriatric anxiety scale. I mean, you can use either, but I wanted to share this with you. Again, you can look at it and you can see what the questions are. And so this is also a validated tool to consider, but it would only be used for older adults because it's a geriatric. GAD-7 is used for across the adult age span. And this is how you score that GAS-10, which is the geriatric version. It's not a version of the GAD-7. It is a standalone screening tool with 10 questions. I'm not going to spend time on it, but you will get my PowerPoint with my citation. So if you're interested in looking at a geriatric scale, you can certainly go there. So anxiety symptoms are grouped into 3 sections. Cognitive, which means thinking. Behavioral, that means how does your behavior change because you have anxiety? And then physiological symptoms, or sometimes we call them somatic symptoms. The primary emotions are worry and fear. You worry, worry, worry. You've heard the word worry what? Or you're fearful. My plane will crash. I'll have a car accident. Constant worry and fear. Or if I get into the elevator, it will stop, or the elevator will come crashing down. So I'm not going to take the elevator and I'll stop going to this building because my meeting is on the 19th floor. I'm just going to quit my job. What are the cognitive symptoms? The thinking symptoms. Many older adults will talk about it as concerns. And they're very common in older adults. So it could be, they will call it, I'm concerned about this. I'm not like, I'm constantly worrying. And then there are behavioral symptoms, like how are they manifested outside of you that we can see them? So you start we call them avoidance behaviors. And you avoid things which produce anxiety. Simple. And so they will become less and less and less engaged because they're avoiding. Remember, we talked about somatic or physical symptoms, and they can be misinterpreted. I told you, frequently people think they're having a heart attack, but it could be rapid heart rate, sweaty palms, it could be diarrhea, dizziness, chest pains, muscle tension. We've already talked about, there is a purpose for anxiety. Remember, I said we all have the fear center in our brain, the amygdala. And it's a very basic emotion for all of us, so like it's universal. It is human to get anxious. And we've already talked about how anxiety can help motivate us to perform better. So it is not always disordered or unusual. But this is what happens in anxiety. Fear. Remember, we said it's fear and worry. We all have fear hardwired into our brain because that's how we survived. Imagine if we didn't have fear, we would probably all be dead by now because we could have been eaten by a lion or stomped on by a mastodon. What is fear? It's a focused response to a definitive threat. And what's it? Flight or fight. We run away from it or we fight it. And guess what? It's very necessary for survival. In generalized or that fear, which is very good, we can overlearn it or we can generalize it to all areas of our life. And that leads to anxiety. That is fear in the absence of a clear danger. That means you're always anticipating. And then that could be good and it could be bad. Because remember, fear is good for us because it activates us to prepare or relearn or rehearse, but it can be harmful when it comes in the way of your everyday life. Now, here's the biology of fear. I told you about it being in the brain, but this is what actually happens when you're fearful. It activates the imperative for flight or fight. And your body is engaged for action, releasing key stress hormones. Look what happens to your when this is surging through your body. Look at the section which says sympathetic. Your pupils dilate. Inhibits the flow of saliva. That's why you have a very dry mouth when you're anxious or in a panic attack. Your heartbeat is accelerated. It dilates your bronchi, inhibits secretion, converts glycogen to glucose, inhibits bladder. Why do you think your heart rate is accelerated? And glycogen is converted to glucose. Anyone? You can just unmute yourself.
Fight or flight is probably getting us ready to like run or
Yes, it
yeah.
is. Yes, for those very reasons. Now, imagine if there is no lion chasing you and you're doing that every day to your body. What what is the toll? Correct? Inflammation, correct? If there is no lion chasing you, or no one running after you with a gun, but that's how you feel. And I'm just picking on two things. There are many other things there that happen to your body. And and so you're constantly activated, and this is the biology of fear, the sympathetic part. Here it is, symptoms of anxiety that activate the flight fight response. This is what happens. You breathe rapidly, you're breathless, you have heart palpitations, increased blood pressure. Why? Because your heart needs to pump more for you to be able to run or fight. Increased muscle tension, sweating, chest pain, all of that. These are the symptoms of flight and fight. Why? Because your sympathetic nervous system is activated. Your body directs hormones such as adrenaline to respond to what you are thinking is a huge looming lion in front of you. And all of this happens without you thinking or planning it. Perspiration, breathing quickens, heart rate, digestion slows down. Why does digestion slow down? Because your body is concentrating on your large muscles, which need to help you run and fight. Here is what people feel: motor tension, trembling, feeling shaky, muscle aches, like constant feeling of like restlessness, autonomic nervous system symptoms, shortness of breath. I can't breathe. I'm going to die. Feeling of smothered. Feeling smothered, like someone is sitting on my chest. Increased heart rate, sweating, clammy hands, dry mouth, dizziness, feeling edgy, all of that list from DSM-5. And so this is how it looks like. Anxious thoughts or beliefs in terms of your mood. Actions or behaviors, you start avoiding specific things or situations because you want to avoid feeling that bad. And then physical symptoms, which we just went over, which could be short and long term. So why are people anxious from all what I've told you so far? They feel they are in danger. That is what we call catastrophic thoughts or catastrophic cognitions. Why? Because they overestimate the probability of something bad happening. Like every time I will board a plane, it will crash, so I'm not going to fly. I'm just giving you like an extreme example. So they have this constant fear that they are in danger. They fear something terrible is going to happen to them. That is, they overestimate the severity of the consequences. And very importantly, they cannot cope. They will not be able to cope. So we've already talked about how anxiety is good, correct? But it becomes problematic when you have this constant sensation of doom, dread, or panic, which becomes overwhelming, and it's frequent or constant. And this is a really nice icon. You can use it as psychoeducation with your clients. You're relaxed and calm. Your brain responds to fight or fight. Your brain sends signals to your body that there's danger. Your body produces anxious thoughts and symptoms, which we were just talking about. Your senses perceive the symptoms as dangerous. Your brain registered the danger from your symptoms. So hey, this is dangerous, and boom, you begin that cycle that you've been doing because of your anxiety, not because there's actually a real danger out there. Here's another way to look at it. I can't cope thoughts. Something terrible is going to happen. Feelings, fearful, physical sensations, behaviors. Try to cope by doing things that help me feel better or keep me safe. Avoid, escape, or freeze. That's the cycle. And the sad thing is there's no real lion chasing you. But that's how it feels. That's what people with anxiety see every day. And so this is how they react. They attack, kick. I mean, they're getting ready to attack, kick, bite, scream, aggressive body posture, or flight, avoid people in places, isolate, escape, only go with someone else or only go with some safety object with them. They're constantly afraid. And the sad thing is there is no real lion.
Nirmala, I want to
Yes.
let you know that we are at the
One
1 hour
hour
mark.
mark?
Yes.
Okay, yes. I think I'm doing okay with time. I better hurry a little bit. Yep.
Perfect.
Here are again. I'm not going to repeat, but you'll be getting my slide deck. These are like the three components of anxiety: the physical sensations, thoughts, or cognitions. That is what ifs, and avoidance and escape is the behavior. We've talked about this already, how you overestimate or exaggerate the actual threat, and you undermine your ability to cope. We've gone over this. This was my depiction of the reptilian brain. That's why you have this little green gecko or something here. But it's really anxiety. You're in this threat mindset all the time. That's the mindset you have. And I know we all talk about de-escalation. I'm not going to go over the slide because that's very specific, but I did put a few slides in about de-escalation. This is the cycle, stages of escalation. It would be futile to try to intervene at number 4, peak, with anyone who is in threat mindset, correct? You need to wait till till it abates for you to be able to intervene. And I'm not going to go over that. We can go, that's a whole different training. Again, I just want to, I've given you a number of icons which you can use as what I call psychoeducation with your clients of all kinds, pictures and emotions, really sometimes a very powerful way for people to remember what happens when you are constantly depressed. We've talked about cognitive symptoms. We've talked less about rumination, but we're going to talk about it. But worry is there. And so I want to talk about behavioral and cognitive approaches now to treating anxiety. One is, in your treatment plan, you should address behavioral avoidance through gradual exposure, address cognitive distortions with that is that catastrophic thinking, address physical symptoms with deep breathing and progressive muscle relaxation or mindfulness, and consider full-blown cognitive behavioral therapy. So worry is like the common symptoms, remember I said? So worry is simply a chain of thoughts and images, usually negatively laden, and you think they're uncontrollable. And it's constant worry. I love this. Worry is the misuse of imagination. It is focusing on the future. It downplays your ability to cope. You can have you multiply your worry with these things we call worry chains, and you believe you can't stop it. So that's the main symptoms in GAD. Significant amounts of time is engaged in worry. And that thing is reinforced with I can't control it. So what do older people worry about? We talked about that earlier. Medical illness, falls, memory loss, which is kind of a little bit different than younger people. Um, so the core feature of GAD is, we call it a what if disease. It's impossible to solve a problem that hasn't happened, correct? Your mind can go in circles for days trying to make the doubt go away. Now, can you imagine how tiring it is? We talked about it earlier. It zaps you of energy. No wonder you feel fatigued. Aside from it disrupts your sleep. Here are treatment options for generalized anxiety. Understanding how worry is an attempt to cope with uncertainty. Becoming aware of what are the things you worry about. Exploring what happens when you postpone your worries. Examine your rules and assumptions about uncertainty. Practice problem solving. Deliberately expose yourself to whatever that hypothetical worry or place that you're afraid of and see what happens. This is just a script of how to talk to your older client or patient to see someone about their anxiety, like a counselor. So I've given you some helpful tips on speaking. I've noticed that you haven't been yourself lately. You seem to be staying in bed a lot more. I'm concerned about you. I'm worried about you. Can we talk about what you're experiencing? It seems like you're going through a difficult time now. How can I help you? Because older adults, mental health is like highly stigmatized. So how do you approach that topic when you're seeing anxieties playing havoc in their life? This is the goal of anxiety treatment. Did you know that? One of your main interventions is you're helping people become more flexible in their thinking patterns. You teach them how to contain and spend less time on worry. And then you help them engage with things that are more important to them and increase their problem-solving ability. That is the interventions. Again, I'm giving you some scripts to how to engage older people in talk therapy just because mental health is so stigmatized. I love this. Frame it as, people don't just go to see a personal trainer when they're completely incapable of lifting weights, although they might, right? But people can also go see a personal trainer just to get a little bit more fit or a little bit more healthy. And so going to a psychologist, social worker, counselor can mean you're getting a tune-up for your anxiety or whatever. So I'm going to spend a little time on CBT because I know I have some time restraints here. And so you all know about this cognitive triangle, correct? Thoughts, emotions, behaviors, and how they all interact. So what you think affects how you feel, affects what you do. And now put all of what I've said into this triangle. Because that's really the basic CBT triangle. And please use this with your clients for psychoeducation. Here is the CBT model for anxiety. Anxiety is in the triangle. You experience, and they're all interrelated, you experience physical sensations. We call that physical arousal. Why? Because you have those stress hormones. It can lead to behaviors like avoidance, safety behaviors. You're going to go to bed and not answer the phone. And it leads to thoughts, this perception of threat. Oh my gosh, something bad is going to happen. And it goes, as you can see, the arrows, they're integrated. And so it's your job as a therapist, counselor, OABHI specialist, teaching a class to explain these 3 Bs: body, brain, behavior. How do you feel in your body when you get anxious? What do you think when you get anxious? What do you do when you get anxious? And you see, you don't have to be a licensed psychologist to teach this. Remember, we talked about increasing the mental health literacy of older adults. I would argue many others too. Because anxiety is the top diagnosis, depression and anxiety, that people are accessing mental health services. Now, imagine trying to explain this in plain English. This little thing here. Here is another way to look at it. This is the cognitive model. Situation, something happens, then you have a thought, that is how you're interpreting the situation. Then you have an emotion, that means you have a feeling, and then you have the behavior, that means you're reacting to it. Here, this is more general, the cognitive model. Your belief is, I'm unlovable. Your intermediate belief, if someone is critical of me, it means I'm not a likable person. And imagine if you're going with that to a social gathering, your automatic thought is, no one will want to talk to me. Remember, we talked about social phobia? Reactions, you'll have tension in your shoulders. You will be quiet and avoid eye contact with anyone. God forbid they come and talk to you, so you will act awkward. And you'll feel very sad, depressed, and anxious that nobody loves you, so nobody's going to talk to you. Here are the 5 components of CBT for older adults. Cognitive restructuring means helping you change your thoughts. Behavioral activation, get up and get going. So don't wait all the time for your thoughts to change. Start doing something and then your thoughts will follow. Teaching them breathing exercises. Teaching problem-solving skills, which we teach through one of our evidence-based depression interventions called PEARLS, but it could be taught by itself. And then social skills training, which is more around, good communication, assertiveness training, all of that. And for anxiety in particular, teaching them to understand the relationship between thoughts, feelings, and behaviors, which I've given you lots of examples about. Here are the cognitive distortions or thinking distortions in anxiety. Overestimating the likelihood of negative outcome. That means they jump to conclusion. With no data, nothing, it's going to happen. And then they do something called catastrophizing, which comes from the word catastrophe. They think about the worst case scenario. In social phobia, they're doing mind reading. People will laugh at me. People will judge me. How are you reading people's minds? So can you see? You're teaching this to your client as part of your therapy. This is, reconstructing their thinking. Remember, they always think of the worst, like negative outcomes, bad things are going to happen. And so you tell them, identify all the possible outcomes to help determine the real odds of that this thing will happen. And then, okay, it'll be catastrophic. Come up with a list of how you will cope with the worst case scenario. Remember, one of the things is that they feel they will not be able to cope, that they'll have a meltdown, they'll faint, some people dizzy, some people say they'll die with shame and guilt. So generate a list of how will you cope with that worst case scenario. What if the train had an accident and you survived? How will you cope? Reframe your perspective. When you're feeling anxious or afraid, think of 3 different outcomes. Outcomes are results to help you change your perspective. Remember, their perspective is always negative. Identify what's bothering you, then imagine the worst case scenario, the best case scenario, and the most likely scenario. Remember, partly it is teaching people with anxiety disorder to live with uncertainty. You can't always predict what's going to happen in the future. That's their way of controlling it. Other technique we teach is play the script. You can reframe further, come up with a detailed plan of what would they do if something, the worst thing happened. This is known as playing the script until the end. So you're afraid of running into someone you don't want to see. You could imagine the confrontational things they might say and how you would respond. Picturing yourself handling the worst case scenario can help you realize you're capable of being resilient if something bad were to happen to you. This can help you manage your anxiety. By the way, anxiety is a lifelong disorder. It will probably never get totally disappeared. What we are trying to teach people is, hey, let me help you manage it so it's not interfering with your everyday living and you have a better quality of life. And one way is playing the script to the end. This is very common in both in depression and in anxiety treatment. Thought log. I don't know how many of you use it. What was the event? What was the thought? What was the action? What was something you could have done differently? Again, you have a presentation in front of a large group. Thought, I'm going to mess it up and I'll make a fool of myself. Challenge. This is scary for me, but I've never seriously messed up a presentation before. Even if I do, what's the worst that could happen? Everyone will forget it in a day or two. Consequence, you're nervous, but not to such a debilitating event. You will give your presentation, and now the next time it will be easier. So can you see how you help them cope? Think CBT. Challenging these negative thoughts, which often fuel, remember, fear, apprehension. Is there any evidence for your thought? Or any evidence to the contrary? Like, hey, I flew on a plane 10 years ago and my plane didn't crash. Am I trying to interpret this situation without all the evidence? If I look at the situation positively, how will it be different? Will this really matter in 5 years if someone laughed at me today? Will it matter in 5 years? Then why am I fretting about it? And then there's something called Socratic questioning. It is from, this is what like Socrates used to do. Similar to the questions I just gave. I love that bottom, the second to the last. Will this matter a year from now, 5 years from now? Can I be misinterpreting the evidence? Am I jumping to conclusions or resorting to a worst case scenario? Am I basing this on a fact or a feeling? So you're actually teaching this to your client. And then there's a proven technique called worry postponement. How many of you use it with your clients? You create a set worry period, a time and a place for worrying. You write down your worries. You go over the list during that worry period. You distinguish between solvable and unsolvable worries. When the time ends, you work real hard to postpone worry to the next worry period. So worry postponement is when you postpone worrying about a thought you're having while you still have the initial worry thought in the back of your mind. However, suppression is trying to get rid of the thought. These are two very different strategies. We are not saying suppress it. We are saying postpone it till that worry time. These are all suggestions for that worry time. Give yourself a worry budget, the amount of time that you will worry. When you're worried about something, push yourself to come up with the next step to take action. Write down your worries. Research has shown that 8 to 10 minutes of writing can help calm obsessive thoughts. Remember, worry is helpful only if it leads to change, not if it turns into an obsessive thought. What are the benefits of worry postponement? Illustrating to the client that typical worry concerns can be limited in number or themes. Allowing them to discover that postponed worries often feel irrelevant by the time they're revisited. Helping them undermine their beliefs regarding the uncontrollability. And it won't happen overnight, so you have to persist in this practice. And also that helps reduce this urgency regarding, oh my gosh, I need to be thinking about this right now. Why is it not suppression? Worry postponement? When someone intentionally suppresses unwanted thoughts, they end up increasing in the frequency. When someone tries to postpone worry with the goal of getting rid of their negative thoughts, what if I can't sleep tonight? They don't succeed and they will experience more of that thought. This is the reason why people don't exceed, so that's you're not suppressing it, you're actually postponing it, where you will write it down and then figure out a solution. And this is kind of a log. You're welcome to download it and use it if you want to teach people worry postponement. There's also, we teach a skill between productive and unproductive worry. Productive worries involve things that we're worrying about that are actually going to happen, maybe a medical test or a job interview. Unproductive or hypothetical. So how you're teaching a client, hey, focus on the productive worries. Let's get rid of the hypothetical worries. We've talked a lot about challenging worry. Here is just another way. One, I love this one. Is this thought helpful? How will worrying about it help me and help you, and how will it hurt you? What would I say to a friend who had the same worry that I have? I don't know any of you trained in ACT for social anxiety. ACT is acceptance and commitment therapy. They use one of their core principles is cognitive diffusion. So here is one for social anxiety. I'm an idiot. That's the thought. Or I can't meet new people. Those thoughts or beliefs are good targets for diffusion. A very quick way to diffuse that is to restate a thought with the phrase, I am having the thought before it, I'm having a thought that I can't meet new people. So instead of saying I'm an idiot, I'm having the thought that I'm an idiot. So that's one way. It's called cognitive diffusion. Or I'm having the thought that I can't meet new people. This changes the relationship with the thought. So we don't get rid of the thought, but we change how we relate to it, that I'm having a thought. It's not your core belief. Many other good ACT metaphors. I love this first one. It is the idea of an informational, a TV commercial for a ridiculous product that everyone knows doesn't work and is junk. Yet somehow it can tempt us into a purchase anyways because maybe we want to believe in it. Our minds can often function in the same way, getting us to buy into certain things and convincing us that they are good, like junk commercials. The other one I really use a lot is the email metaphor. Don't hit send. We may ask Charles how many emails he receives each day and whether he opens every email and reads them. And to what degree does he give the same attention? Most people would say no, they open the ones they must or want to read and ignore the rest. And we can take that same approach to our thoughts if we choose. The thoughts are useful, can be given more weight. Those that are don't need to be can be gotten rid of. So you're actually using this email metaphor with your client. So ACT in action. ACT has established that it's very difficult not to think about something. So in ACT, using that diffusion method is what they use. They don't tell you like stop thinking about it. How can we diffuse the thought so that your relationship changes to the thought? And then there is the safety behaviors. That's part of that behavioral part of anxiety. Remember, we are all hardwired to protect ourselves from dangerous situations. And when we experience a threat, we go to great lengths to keep ourselves safe. If you were in an unlit parking garage and you heard footsteps behind you, it's likely that you'll move faster and you'll get to the safety of your car. In addition to seeking safety, to this physical situation, you will find yourself seeking safety to alleviate anxiety you experience when you worry about something. Safety behaviors are chosen actions that are carried out to protect you from fear and from what you imagine are catastrophes. So it's a range of behaviors. And these behaviors are used to neutralize the feelings of anxiety. For example, reassurance seeking, behavior rituals, safety cues and objects, over preparations. So there are two behaviors, avoidant behaviors and approach behaviors. With avoidant behaviors, safety behaviors, we just avoid those situations and totally escape. But in real life, you can do that with all of your life, right? Approach safety behaviors, you engage in an anxiety-provoking situation, but you use strategies where you think it will minimize your feared outcome. So there are the two kinds of safety behaviors, okay? And as you can see, I'm going to give you the list of behavior. Here are some things that people do. Avoidance, like you just don't fly on planes. Excessive reassurance seeking. Distracting yourself. Procrastination. Checking and double checking. That very often happens with like OCD and compulsive behaviors. Over preparation. Perfectionism. If I can't do it well, it's not going to happen. And many rituals. I'll touch this rock before I leave my door, or I have to tap 3 times so then nothing bad will happen, or I'll only get into an elevator with someone else. Those are all safety behaviors. And so what has happened is, what does the brain need to learn to not fear a stimulus or a stressor that isn't truly dangerous? We talk about exposure. That means we want to expose people to the very thing that they're afraid. If they're afraid of elevators, we want to gradually expose them to getting into the elevator and going up to the 17th floor. So it's called exposure therapy. Here is relaxation. You're teaching your client psychoeducation. Remember what happens to the sympathetic system is activated, then you want to calm it down. You want to calm it down. You do it by these things. Deep breathing, diaphragmatic breathing, progressive muscle relaxation. And you tell them what the science is behind it. How can you use wisdom with your older clients? How did you cope with major challenges at different points in your timeline? Can you share positive memories of personal achievements associated with specific events? Are there moments in your life you consider pivotal? What strengths did you draw upon during various phases and challenges in your life? Are, are there aspects of your character that you believe have contributed to your well-being? How have you evolved as a person? What aspects of your journey are you proud of? Here, you're building resilience in CBT for older adults by asking these questions, especially for anxious older adults. There are some limitations for CBT for older adults, especially those who have substantial cognitive decline. Cognitive restructuring and all may be difficult. And then really collaborating with caregivers would be very important. So here are some modifications for older adults: slower pace, using memory aids, like writing down visual aids, written notes, all those little icon graphics I showed you. Very simplified homework. Focus on psychoeducation, and I've given you lots of tips and resources for your adaptation. You may need to do some reminder phone calls, not for appointments, but about the homework assignments. Okay, for older adults, with them and also with their caregivers. So adding memory and learning aids to CBT for anxious older patients may improve their response rate to what you're teaching them. Here are what I said, contraindications for CBT. If they have very high levels of cognitive impairment or very advanced dementia, they have severe depression with psychotic features, they're not a good candidate. Lots of high levels of anxiety with agitation, severe medical illnesses. It's not the frontline best practice to use CBT. I'm not going to go over all of these, but this is really a very quick interventions, which is focus on your breath. Why? Because it regulates your nervous system, it activates the parasympathetic system, and it quickly brings your body down from flight and fight. Here is examples of what you can teach called box breathing. Do you know which part of the military it is mandatory to teach and use box breathing? Anyone wants to tell me? Of our military.
The Air Force?
No, Navy SEALs.
Yeah.
Oh, okay.
They do some of the most dangerous work, which is very anxiety provoking, right? They're going into enemy territory to rescue someone whose plane is down. They have mandatory training on box breathing to activate the parasympathetic system. So here I'm giving you some instructions on teaching your clients, and anyone can teach this to anyone. Here are the benefits. You can even teach it as a psychoeducation. It lowers stress. It activates the parasympathetic nervous system, which we were just talking about. It calms the mind. If your person cannot follow, inhale, exhale, all of that, this is a very simple adaptation for people who have cognitive compromise of some kind. It is called smell the flower, blow the pinwheel. I don't know how many of you do know that, because when you smell the flower, you're inhaling. And when you blow, you're exhaling. So this is another way to teach this same box breathing to people who may have some cognitive challenges.
You can also swap out the pinwheel for a candle. I use
Yes.
smell of flower,
Yeah,
blow out the
candle
candle
too.
with
Blowing the
kids.
candle. Blow the
Yeah,
candle.
because that's an easier thing to
Yes.
access for most people than a pinwheel.
All right. Absolutely. Yes. Again, I shared this earlier. Worry is a waste of imagination. Please share this with your anxious clients. Again, we talked about mindfulness, teaching mindfulness. Why? Because it's present. You focus on the present. Remember, anxiety is future oriented. You're hypothetically worrying about something going to happen in the future. Say it out loud. Actually saying it out loud or writing it down actually diminishes its power. Don't ruminate. If you're saying, what if? It's a clue that you're ruminating. If someone says, I don't know whether I ruminate, if you're saying, what if this happens, you are ruminating. Stop and ask yourself, what steps can I take? So really focusing on rumination, which also happens to be a core symptom of depression. We've talked about this, visualize your worries and then, rate it on a scale of 1 to 10, or then just allow it to blow away. Using self-statements to mitigate anxiety. I used to teach this. Fear is a belief and belief can be changed. Feelings are not facts. Bear the discomfort in order to achieve the comfort. Or we used to also say this shall pass, that you're not having a heart attack. Just sit in that discomfort, it will go away. Nervous symptoms and sensations are distressing, but they are not dangerous. You are not having a cardiac event. How many of you encourage your clients to cultivate personal assets, where you're helping them grow their emotional muscles? Tolerance for uncertainty, desire to help others, staying flexible, patience, cultivating optimism, using humor, confidence in your ability to cope. Those questions I gave you about how to harness wisdom and resilience with your older clients. You're looking at how did you cope earlier in your life. You're boosting their confidence or their self-efficacy for their ability to cope. Increase your psychological capital. And it's hope, optimism, resilience, and efficacy. That is, I can do it. Education and lifestyle modification. Our goal is managing anxiety rather than erasing it. So make note of that in your treatment plans. Educate about the cycle of anxiety. Regular exercise counteracts anxiety and depression, might I add. You're giving this psychoeducation and lifestyle. Practice hygiene, sleep hygiene. Avoid all of these kind of activating substances. Here are other complementary treatments, yoga, acupuncture, massage, art, music, meditation, prayer, all of that. This is more for people who live in long-term care settings. What can you tell your resident who is anxious? Take some deep breaths. Why do you think that might happen if they're having these catastrophic thoughts? Have you had a similar worry in the past? Is it possible it might not happen? What would you say to a friend? These are like bedside interventions in long-term care. Again, I talked about those little phrases that you can teach people. This shall pass. This is uncomfortable, but not dangerous. Everyone has worries, looking at that worry postponement that we talked about. Here are brief interventions. Psychoeducation is key. I don't know how many of you use psychoeducation, teaching all those kind of relaxation techniques that we talked about, and to activate your parasympathetic system. We've talked about how to reconstruct your thinking, exposure therapy using affirmations, really promoting good sleep hygiene. Here are all the best practices. I am not talking a lot about pharmacotherapy because I'm not a prescriber and that's not my area of expertise. Very quickly, Matthew, if you have something quick, I can take it.
Can you go back 2 slides for a moment? So the issue here, I'm a adult foster care coordinator for mental health. And
Yes.
Many of the programs are either receiving citations or they're not properly doing activities. And the use of activities and why it's required is exactly this, that the activities in a foster home is a way, or in residential, is a way of reducing anxiety and taking somebody to a different area of their being. And so I just wanted to highlight that, when I'm at licensing reviews and I'm seeing citations either for not doing activities or not doing activities as the ORS is talking about, it really impacts that particular slide.
Yeah, absolutely. Yes. Yeah. In fact, I was in a nursing home yesterday talking about anxiety. So yes, absolutely. I am no prescriber, but I'm just giving you some information on medications. Please consult with your team if you'll have a psychiatrist or a nurse practitioner. These are all the medications currently. SSRIs, SNRIs, TCAs are tricyclic antidepressants. They're not used as much because they're very cardiotoxic and anticholinergic, especially for older adults. There's all these benzodiazepines, which should only be used very carefully for short term. And always combining it with psychotherapy. Bottom line, anxiety disorders are underdiagnosed and undertreated in older adults, especially when their clinical presentation differs from younger people. Late life anxiety symptoms is a manifestation of stresses, losses, depression, coexisting medical problems, could be substance use, medication side effects, withdrawal symptoms, or general disability. Psychoeducation is a powerful intervention to increase the mental health literacy of your older clients. Effective treatment may include pharmacotherapy, psychotherapy, and complementary and alternative therapies. These are wonderful 2 resources to go to if you're looking for quick interventions for, to use with your clients or in your residential treatment homes, wherever. Very good resources to go to. This site is called Keltiski. Very, very good stuff. Here are all my resources. If you have the time to go through them, I would highly recommend this book for therapists and case managers. If you don't already have it, ask your organization to buy it, because I just told you what is the prevalence of anxiety for older adults. It's called the Aging Well Workbook for Anxiety and Depression. It is available through Amazon. This is free for you to download. I've given you the link there. A Provider's Guide to Brief Cognitive Behavioral Therapy, which includes therapy for anxiety. This is an excellent patient workbook. Look at it. Calmer Life, a CBD-based treatment for anxiety in older adults without depression. Please take it, use it in your senior centers, in your adult care homes, even in your mental health programs. Free to download. It's a workbook. Again, how to adapt cognitive therapy for older adults. This is a consensus statement. Please read if you're interested, or even putting together a resource book. This will be a very good document to include. Very quickly, I'd love for you to all put into chat what is something you learned today, something new, and what is one thing, like a skill or something I told you, that you will take and use in your practice tomorrow with older adults that you work with. So I appreciate you all inviting me again. Thank you very much. And
So we
Louisa.
have a number of questions,
Okay,
Nirmala.
I have about 7, or I would say 6 minutes, because I have to
Okay.
leave at 5 to
Perfect.
11. Yes. Thank you
So
all for being with me, sticking it out. I appreciate you all being here.
nice. So some of the questions are around, can you speak to the sociological aspects of gender? If a person transitions from male to female, does that create the same results for stress? If a woman transitions to male,
Right.
does she maintain the same
Right.
level of expected stress?
So, there are two like socio-cultural biological reasons. One is very much it's hormone driven. And, there's a whole body of work on women's mental health through the lifespan. If you see women at a high risk during pregnancy, postpartum, menopause, all of that, because it's hormone driven. So the second reason is that women are socialized to ask for help more than men. So them being diagnosed more is probably that plays a role in it. That women come and seek help and therefore get diagnosed uh, more often, and that applies to other mental health diagnoses too. So it's a combination of, I would say, biopsychosocial, cultural. So I am no expert on the biological impacts of what happens when you transition from one sex to the other. So I'm not an expert in this, but I'm just telling you from my reading and my work over the years that there's definitely hormones play a part in women's mental health throughout their lifespan and puts them at risk at distinct periods in their life. And that there's also culture and socialization that happens for women. So that would be my. So again, this is not any kind of expert opinion. This is what I have observed over my time working in this field.
Great. The next question is there a difference between worry postponement and compartmentalizing?
Yeah, worry postponement is you're teaching them a skill, where you're trying to contain their worry into one discrete time period, and it's not just containing the worry; they're supposed to write it down, and you're simultaneously also teaching them the skill of problem solving. Remember, they have to look at that list and say what's solvable, what's not solvable. If it's not solvable, you're working with them to throw it out the window. And then you're teaching them, hey, if this is your worry, what are some steps you can take to solve it? So it's very, very different.
Okay. I think that might be all of the questions that we have. So, Nirmala, thank you so much. And you are dismissed.
Okay, well, thank you, everyone.
Yeah.
Hopefully, I'll come back one of these days. Take good care. Bye.
Thank you. So just to reiterate, everyone, that we will be sending you an email with a PDF of the slides, a link to the recording, and all of the different assessments that Nirmala mentioned, especially the GAD-7 and some of the other ones for you all to have. And then if you want CEUs, please return the survey, and we give you about 2 weeks once we send it, about 2 weeks to do the survey. So make sure that you do it in a timely manner. And we will send just a regular evaluation also to everyone. And we would love to have that evaluation done for everyone. Okay, so we will see you possibly next month for our Beyond Bereavement Gero competency training. And we hope that you enjoy the rest of your week. Thanks.
Thanks, Angela.
You're welcome.
Ta-ta.